Hello, this is Jay Eargang, and in this presentation we'll talk about selection, collection, and interpretation of clinical outcome measures. So as we saw in our previous presentation, we can increase value by increasing the health outcomes achieved or decreasing the cost for achieving those outcomes. And this implies that measuring value inherently requires measuring health outcomes. These health outcomes, as we talked about before, must be patient-centered. That is, the outcomes of the care that you're providing to the patient are important to the patient. So what outcomes are most important? Again, it's going to be the patient's perception of their symptoms, activity, and participation. So what do we need to think about in terms of selecting clinical outcome measures? First, we have to think about what's the purpose of the measurement, what are the psychometric characteristics of the measure, that is their reliability, validity, and responsiveness. Are the outcome measures relevant to the patient population? And what's the burden associated with collecting these measures on the patient as well as the clinician? And we're going to discuss each of these in this presentation. So when we think about purpose of measurement, we can use this measures to discriminate between subjects or groups. That is, perhaps to classify or to diagnose individuals. We can use measures to predict their current or future standing, or we can use them to evaluate the change in their condition over time. So discriminative measures, again, trying to classify or make a diagnosis. Predictive measures are really looking at the prognosis, or again, predicting their outcome. And evaluative are used to assess outcome. So in terms of measuring quality and value, we want to measure change over time. So these have to be evaluative outcome measures. So when we think about the psychometric characteristics for selecting an outcome measure, we have simple one-word definitions of reliability, which is consistency of measurement. That is, if the patient's condition does not change over the time where you're measuring them repeatedly, you should get the same scores. Validity is accuracy. Is the score really measuring what you're intending to measure? And responsiveness is the ability to detect change. And this is what we want with our outcome measures, to evaluate the change of the individual over time. And we need evidence that that measure is indeed responsive. So reliability, again, means that repeat observations over time should remain stable when the individual's condition has not changed. That is, the variation within a subject should be small when there's no change in the patient's condition. Validity is the change in the score should be related to other measures of change, and responsiveness implies that the score should change when the underlying condition measured by the instrument changes. There are two broad categories of patient-reported outcome measures, general and specific. Specific outcome measures can be disease, region, or patient-specific. So when we look at general patient-reported outcome measures, these are applicable to diverse patient populations. That is, you could use it for somebody with low back pain, neck pain, shoulder pain, a cardiovascular condition, a neurological or neuromuscular condition. So the same measure would be applicable to all of those patient populations. And these usually measure multiple aspects of health status, such as physical, emotional, or social health. Examples are the Veterans RAND 36, which consists of 36 questions, or Veterans RAND 12, which consists of 12 questions, are the most common examples. A newer example is what is known as the PROMIS Global 10, that broadly measures physical and emotional function. And this measure is being proposed to replace the Veteran RAND or the SF-12 measures. The advantages of general patient-reported outcome measures is that they permit comparisons across populations with different health conditions. In other words, you can look at the impact of low back pain and compare that to the impact of a cardiovascular condition, for example. Okay. They're more likely to detect the unexpected effects of intervention. That is, since they measure both physical and emotional health, you may actually see improvements in emotional health that you may not have been able to measure or to detect if you used a specific outcome measure that focused only on physical function. The disadvantages are that they are less responsive. They're susceptible to floor and ceiling effects, and what I mean by that is they are susceptible to having individuals score at the maximum or score at the bottom or lowest possible score. And when you're at these extremes, there's not much range for improvement. The content may appear less relevant to the patient. So, for example, some of the questions on the VR-12 are, how often do you feel downhearted and blue, and so forth. And patients may question why you're asking them that type of a question. They're also longer and more difficult to score. Now, in comparison to general, there are specific patient-reported outcome measures. And these focus on aspects that are specific to a primary region of impairment, a particular disease or condition, or a particular population. And it includes only those important aspects of symptoms, activities, or participation that are relevant. So the spine-specific patient-reported outcome measures that we're going to be dealing with are the Oswestry Low Back Disability Index for low back pain, the Neck Disability Index for cervical pain, the Roland-Morris Scale, which has been developed for low back pain, and the Swiss Spinal Stenosis Questionnaire, which is for spinal stenosis. The advantages are they generally have improved responsiveness, they're short and easy to score and easy to interpret, and the content is more relevant and therefore more likely to be accepted both by patients and clinicians. Disadvantages is that they don't measure all aspects of health status. They only measure either pain or physical function or perhaps other symptoms. They don't measure social or emotional functioning. They don't allow for comparisons between different disease states and or populations. So you can't use an Oswestry Low Back Disability Index to evaluate the effects of treatment for somebody with neck pain or somebody with shoulder pain. These measures, these patient-reported measures, also have to be relevant to the patient population. So some of the work that we've done looking at acceptability of patient-reported outcome measures to patients with a variety of orthopedic or musculoskeletal conditions has indicated that measuring physical function was important to the patients as well as to the clinicians that cared for these patients. The patients are willing to complete these patient-reported outcome measures, but experience dissatisfaction when asked questions that were not relevant to their condition. And clinicians stated that the measure should be targeted and customized to individual patients, and they should be able to be completed within a short period of time, and most people are willing to put in 5 to 10 minutes to complete these measures. In terms of relevance, the patients must be involved in reviewing and selecting outcome measures. The items should be relevant to the patient given their region of impairment and the level of function. For an example, for an individual with low back pain, appropriate items might include sitting, standing, walking, lifting, carrying objects, but not items related to upper extremity functions such as writing or placing an object on the shelf. For low-functioning individuals, items representing higher order activities like running or jumping would not be appropriate. And you also have to consider the wording and clarity of the item. For example, the question, does your health now limit you in doing vigorous activities such as running, lifting heavy objects, and participating in strenuous sports? This single question is actually asking the individual 3 separate things. How much problem do they have running? How much problem do they have lifting heavy objects? How much problem do they have participating in strenuous sports? And it may be hard for the patient to demonstrate an answer to this, a single answer to this question. So when we look at the implications of relevance and the burden of measurement, that has implications for how we're going to measure patient-reported outcomes. And there are new modern measurement methods, namely item response theory and computer adaptive test, that can be used to help improve our outcome measures. And the underlying premise of item response theory is that the performance of an individual can be modeled by the characteristics of the person and the item. That is, the way an individual answers a question is based on them, themselves, as well as the difficulty of the item. And this premise is used in item response theory. So essentially, when we utilize item response theory to measure a patient-reported outcome, we start by creating what is known as an item bank. That is, we get a large number of items together, and we calibrate or score those items on a scale that is measuring what we're trying to measure. So for example, here, our scale may be mobility. And we can measure the scale from low to high mobility, and we can locate the items on this scale. So for example, walking a block might be kind of an intermediate level of mobility, whereas turning in bed can be performed for those at lower levels of mobility, whereas running a mile requires a higher level of mobility to be able to do that. And we can continue to link items on the scale. Walking across a living room is somewhere in terms of difficulty and somewhere on the scale between turning in bed and walking a block. Okay, rising from a chair is in between turning in bed and walking across the living room. Climbing one flight of stairs is somewhere between walking a block and running a mile in terms of difficulty, and walking a mile is somewhere in, a little bit less difficult than running a mile. So having this calibrated item bank allows us to use computer algorithms to select a subset of questions that are best in measuring an individual's patient mobility. And if we, no matter what questions we administer and score, we can place the patient somewhere on this ruler of mobility, even if they don't all respond or answer the same questions. So this can be used to create what is known as a computer adaptive test. So as an example, based upon the individual's age and sex, the computer will select an initial question. So perhaps for a 25-year-old male, the initial question might be, can you run a mile? The response to this question is going to determine the next question. So if the individual is not able to run a mile, the computer would bypass harder questions, for example, running 5 miles, to select questions that are easier, such as can you walk a mile? And this process will continue iteratively until a predetermined number of questions are administered. And typically, these computer adaptive tests only require 4 to 6 questions to precisely measure an individual on the scale that you're measuring, such as mobility, as we showed in the prior example. There are multiple computer adaptive tests that have been developed by the PROMIS network. These can be obtained, and you get more information about these at a website called healthmeasures.org. This is an organization that is based out of Northwestern University in Chicago, and they have developed and have available multiple computer adaptive tests to assess physical health, mental health, and social health. So the ones that would be most relevant for patients with spinal pain would be physical function or pain interference, how pain interferes with their ability to do everyday life, as well as perhaps some mental health questions such as depression and anxiety. And these PROMIS computer adaptive tests are likely to become more widely implemented and used in orthopedics as systems to administer these computer adaptive tests evolve. That is, they start to become integrated within the electronic medical record. So now let's switch and talk a little bit about clinical outcomes data management. What do we mean by this? So now this is the process of data collection, analysis, and interpretation of the effectiveness and efficiency of patient treatment for the purposes of improving the quality of care and lowering healthcare costs. So when we collect patient-reported outcomes, we want to collect those at the time of initial presentation, at regular intervals during the course of care, as well as at the end of care. And ideally, we would like to get some sort of long-term follow-up. So a year after you've seen the patient, how are they doing? However, collection of these patient-reported outcomes alone is insufficient for quality and performance improvement initiatives. Other information that is needed for meaningful interpretation of patient-reported outcomes data are that we need information about the characteristics of the patient, their age, their sex, their BMI. We need their classification and their diagnosis. We need to know comorbidities and other risk factors. So, for example, things that might impact their outcome, like diabetes, smoking, the START-back score. We also need to know what you did with the individual, how many visits, what interventions were provided by the primary spine practitioner or others. Were any diagnostic procedures done, radiographs or MRI, and were any other pharmacologic or non-pharmacologic interventions utilized to manage this individual? So NSAIDs, opioids, injections, and surgery. So all this has to be considered when we're evaluating the patient-reported outcome measures to assess the quality and value of care provided by a primary spine practitioner. So use of clinical outcome measures to make individual patient management decisions. Okay. In other words, did a patient have a meaningful outcome, or did they fail to progress? Did the patient get better? So we can define a meaningful outcome based on a change that is greater than measurement error. That's called a minimal detectable change. Or an important change. to achieve a meaningful outcome, they had to have a change that they deemed to be important, and that is a minimum clinically important difference. Or perhaps you might want to get the patient to say that the current state of their low back pain or their neck pain is now acceptable to them, and that is what is known as a patient acceptable symptom state, or a PASS. Or perhaps we might want to compare to population normative data. So while this example is based on a patient with a knee problem, I believe it provides a good illustration of how we can look at whether or not a patient had a meaningful outcome. So again, while it's not directly relevant to the spine, let's go through this example. So we have a 33-year-old male that is 12 years after reconstruction of the anterior cruciate ligament, and he now has a 2-centimeter lesion, chondral lesion on the medial femoral condyle. And he complains of persistent pain and swelling over the last 12 months. And his baseline IKDC subjective knee score is 55. The IKDC subjective knee form score is a patient-reported outcome measure that's specific for the knee. The intervention is the individual undergoes surgery for a microfracture in February of 2010. At the 1-year post-op visit, the individual's IKDC subjective knee form score has improved now to 82, representing a change of 27 from baseline. So the question is, did this individual achieve a meaningful outcome? So we know that the minimal detectable change for 12 months for patients undergoing an articular cartilage procedure is about 13 or 14 points. This individual had a change of 27 points. So his change was greater than the necessary improvement beyond measurement error. So that change is likely to represent a true change, not just measurement error. The minimum clinically important difference at 12 months for patients after an articular cartilage procedure is about 17 points. So therefore, the improvement experienced by this patient is likely to be deemed important by the patient. The patient acceptable symptom state threshold for individuals 1 to 5 years after ACL reconstruction is about 76. This individual's IKD score is now 82. Therefore, this individual would likely perceive their status to be satisfactory. However, the population average for males 25 to 34 years of age is 94. Therefore, this patient, even though they have a change that's better than measurement error, that would be considered important, and their status would be considered satisfactory, they're still about 1 to 1.5 standard deviations below the normal, the population normal score for individuals that are men 25 to 34 years old. So while they're improved and they're feeling good, the individual may not perceive themselves to be normal. Now let's take that and look at an example for low back pain. So now this patient is a 33-year-old male that has an acute episode of low back pain and left body pain of 6 days duration secondary to a lifting injury. At the time of presentation to the primary spine practitioner, his modified low back pain questionnaire score is 35, indicating a moderate level of severity. Based on the clinical prediction rule for the use of spinal manipulation, you decide that you're going to perform spinal manipulation for this individual. At the next visit, coming back to you 4 days later, the individual's score is now 31. Okay? So is this patient improved? Did this patient have a meaningful outcome, going from 35 down to 31? So basically, we can see here that the change in the modified low back disability questionnaire since the prior visit is 4 points. However, based on work that we've done, the minimum clinically important difference for the modified low back disability questionnaire is 6 points. So therefore, it's not likely the individual perceives his change in status as being important. We can use this information as part of our patient management. While the patient looks like they've had a little bit of improvement, it's still probably not enough improvement that the patient would say that it's an important change. And we might use that in considering how we're going to follow up and treat this patient at this time. So perhaps you might do another session of spinal manipulative therapy. So in summary, what we've tried to do is to provide an overview of how we would select, how we would collect, and how we would use and interpret meaningful patient-reported outcome measures. Thank you.